Welcome to Heartline, conversations with healthcare changemakers following their heartline. I'm your host, Dr. Andrea Austin. I'm an emergency medicine physician, coach, and educator. I believe that healthcare needs to improve the quality care that patients receive and that supporting the workers is at the heart of this transformation. I am thrilled to have Susannah Fox. She is a health and technology strategist. Her book, Rebel Health, A Field Guide to the Patient-Led Revolution in Medical Care, was published in February 2024 by MIT Press. I was reading it so ferociously this morning in anticipation of this podcast, and it blew my mind. So I'm very excited to share her with all of you. She is also former Chief Technology Officer for the U.S. Department of Health and Human Services, where she led an open data and innovation lab, which I have to know what that means and understand that more. She has served as the entrepreneur in residence at the Robert Wood Johnson Foundation and directed the health portfolio at the Pew Research Center's Internet Project. Susannah Fox, it's wonderful to have you on the podcast.
Thanks for having me.
I usually start this question later, but I think it would really help our audience get to know you. Could you describe a revitalization moment in your career? And for our listeners, the revitalization moment is when you had an inflection point and then you had some clarity on what to do next.
What a great question. An inflection point for me was when, as a researcher, I was invited to partner with the National Organization of Rare Disorders. I had previously done fieldwork in other online patient communities, people living with cancer, people living who are facing pediatric challenges. But this was a chance to dive deeply into communities where people had really been knocked down by healthcare. They had been dropped into a dark maze, and they were calling out to each other to try and find each other in the maze, because it was not likely that they would ever meet someone in their town or even in their state who had the same diagnosis, but they'd been able to find each other online. And I got to tell you, I had spent my 20s building websites, and then in my 30s, I transitioned to being a researcher, but I hadn't really found my path yet. It was in doing that fieldwork that I realized that peer-to-peer healthcare, this connection that happens between and among patients and caregivers, that is the megatrend that I think is going to transform healthcare. And that's what set me on the path to actually leaving research and eventually writing this book.
I want to come back to the term peer-to-peer healthcare, which is a term that you actually coined. I want to go back a little further to understand how you had this lens that paved the path for your career. Some of the listeners are probably saying, she's not a doctor. Andrea often has doctors on this podcast. Can you tell us a little bit about your educational background? And the reason I'm asking this is going to come out later. It just helps me understand the lens that you were able to write this book and how you were able to move through so many different worlds of tech and research and government.
Well, I'll start at the beginning and say that my dad was an engineer he had convinced my brother and my sister to become engineers. And my mom is a writer. She was a dance critic and then a business writer. And so I grew up really comfortable with code, really comfortable with technology because of my dad. And I grew up being invited into creative spaces because of my mom. I also want to share that both of my parents stepped forward into caregiving when the family needed it. And I followed them into that work as a caregiver for elders in our family. So that's been a lot of what has been part of my education as a person. In terms of formal education, I studied anthropology, which means I think of anthropology as a license to be professionally curious and politely curious about other people It's a way to look at society from a systems perspective. And that is the orientation that I brought to my life as a researcher and an observer of this intersection of healthcare and technology.
Now everything makes so much more sense. I just love that your background's anthropology. And before we started recording, I shared with you that one of my passions is medical simulation. And she's an emergency physician, but she's also an anthropologist. Her name is Eve Purdy, and she does research on essentially the culture of medicine and uses her sim lab as a kind of an experimentation zone. She lives in Australia. Anyway, her work may be of interest to you with your background in anthropology. I think it's an example of a field that I think doctors, one of our drawbacks is many of us were biology majors, myself included, so I'm critiquing myself. And then we went straight to medical school. And because of that narrow lens, I think it really impacts our ability to think creatively and to also have a wider understanding of the lived experiences of people. So that's kind of my long way back to this book that you read with this patient-led healthcare revolution, which is, I will say, most doctors, when we hear that, are concerned. I think that would probably be the first word that a lot of doctors would say. And I think a lot of it probably comes from, frankly, probably PTSD from the pandemic. And we saw misinformation on steroids. I don't think I've ever seen, I always knew misinformation was a problem, but the ferociousness of it during the pandemic. And I think what was different, and I'm thinking out loud and creating as we're in this conversation, is the misinformation that occurred before the pandemic rarely hurt me. It may hurt my patient, but the misinformation that occurred during the pandemic began to feel life-threatening to me. And I've just put that together about why it was such a powerful, disturbing time to practice medicine. I'm wondering, with your background in technology, what can we do about misinformation? And I think that's the number one thing that makes us as doctors scared about patients entering into the peer-to-peer relationships and chat rooms and Facebook groups that, as your book shows, can be very good and powerful.
Thank you for bringing up misinformation right away and for calling it out for what it is, which is a national threat. It's a personal threat, as you just talked about, and it's a threat to our communities and it's a threat to our nation. And just like in the pandemic, which triggered a whole of science and whole of government response, whole of society response, we need that same response for misinformation and disinformation. And my message is that we should not throw the baby out with the bathwater. We can't stop peer-to-peer healthcare. It is a tenacious human need to connect with someone who shares your same life stage or diagnosis, to trade ideas, to teach and learn from each other. That's happened, by the way, since humans could gather and communicate. And what the internet and technology have done is accelerated it, and it's widened the scope. It's allowed people to connect across time and space. And we can harness peer-to-peer healthcare in the response to misinformation if we give people access to the facts, if we give people access, for example, to the medical journals that are currently closed to people. Medical journals should have open access policies for important findings, whether it's about fast-moving situations like COVID-19 and vaccine, or whether it is something that a family might be facing in terms of a treatment option, so that people can have access to the information that they need to make a good decision. I talk in the book about the 4 types of people that you'll meet, and we'll probably get to that. But I'm going to call out one of the groups right away because I think they're really powerful for this part of our conversation. And that is people who are networkers. People who are networkers are people who can't help but either join or form a group. They are people who are going to gather other people like them around them. Again, whether it's offline in a neighborhood or a faith community, or online, like on a Facebook group or a dedicated website for patients. They are so powerful. If they find something good and useful, they can't wait to share it. How might we help them to share science? How might we help networkers to share the very real news that science is not always settled? And we saw it in the COVID-19 situation where we were all learning across the world about what this virus is going to do, how we can stop it from spreading. And as we learned more, we needed to very quickly communicate that. And the government can help, clinicians can help, but let's not forget the patients and survivors and caregivers, the consumers out there who are very natural communicators who can help us fight against misinformation.
I love what you're saying. And after kind of screaming into the void during the pandemic, I actually took some time and reflected on, I'm upset right now that people are sharing mis and disinformation. And that I'm forced as an ER doc. We have a policy, we have EMTALA, that we see everybody that comes through our doors. So I had people screaming at me that they didn't have COVID and wouldn't wear a mask. And to have that breakdown in the trust. And so I had to spend some time thinking about, what is actually the doctor's role in this? How did we get here? And it's a complicated issue, right? It's a dilemma. If it was a problem, it's easy to solve. A dilemma is more challenging. I think part of the problem is we've lost trust. That for instance, I grew up in a small town. The small town doctors were embedded in our community. They went to the high school games. They knew our family. They knew our story. My dad still lives in that small town, and he's going through a health challenge right now. And I've had very close communication with his doctor who knows our life. And living in a major city, San Diego, I've never had a primary care doctor for more than, I think, a year. They've just been very transient. So I kind of have this feeling that in order to get to a place where we can be in dialogue with our patients again, we have to restore trust. And I'm wondering what your research, since you're much more closely in communication with patient communities, what's your take on that? And what could we do to start to build some of that trust back?
Trust is incredibly important. And the communities where I've spent time have all been communities that I like to call pro-social and pro-science. These are people who are in active treatment very often, or if they're still searching for a diagnosis, they know that science is going to be the answer to finding a diagnosis, for example, for their child who's living with a rare condition. So these are people, for the most part, who are not turning away from science, but are looking for answers not only in the published literature, not only in the evidence base, but also in the experience base, also in the communities that they're forming where people are sharing their own stories and collecting their own data because nobody else is looking at the problem as closely as these fellow patients and caregivers. And I think that one way that in my interviews with people, they talked about building trust with clinicians is when a clinician asks them a question that is respectful of their research, that is respectful of the fact that they know that they are probably going to go online. As soon as the appointment is over, they're probably going to go online and consult Dr. Google, or they're going to go online and look for an online community. And one way that doctors can build back trust is to acknowledge that and say, I understand that that's what you're going to do. So let's make sure that you're spelling the condition right. Let's make sure that you understand what I've given you so far so that when you research it online, here's, maybe, and by the way, instead of just putting it straight into Google, can I suggest these websites? It'll build trust to be able to say, look at PubMed. In addition to joining a Facebook group where you can get that lived experience insight, here's a place where you can get the insights that we clinicians and scientists are talking about among ourselves.
Yeah, I want to circle back to this idea of patients not being able to access the medical journals. And actually, I think I was on Threads this morning and posted saying that it's not just the patients, it's also my colleagues that aren't in academia. I'm fortunate I still have an academic affiliation and I can access pretty much any article I want, but I have so many colleagues, physicians in community-based practices that can't access these articles. And I'm wondering if you have any solutions. And my idea is if we look at where the money is in healthcare, obviously insurance companies have a lot of money. And could one of your benefits of having healthcare insurance be that you get access to some of these journals, or essentially like you have credits that you could use, or if you get a serious diagnosis, which I kind of say serious, I mean, every diagnosis is serious. Would that be a potential solution, or what do you see as some ways to get the information out there?
Well, one way to think about it is that so much research is funded by the federal government, just talking about the US here. And so the American people have already paid for this. The American people have already paid for that research to be done. If it's a grant through the NIH, for example, why don't the American people have access to that information?
So if you accept an NIH grant, part of the terms would be that the article is open access.
Absolutely.
Because I've published a fair bit. There's usually an option as you're going through, once your article is accepted, that you could pay a fee for it to be an open access. It's usually like $2,000. So essentially, if you have an NIH funded grant, part of which these grants are often millions of dollars, you would just put that in, that the
it
open
should be
access.
Folded in. And there has been some policy movement in that direction toward open access. And what I would say is, having spent time for the last 20 years talking to patients and caregivers who want to do the right thing, they want to rely on the latest science to make decisions for themselves and their families, that policy should move more quickly. And again, if we want a whole of society response to misinformation, why are we locking up vital information out of the hands of people who really need it, who can, just as misinformation can spread peer-to-peer, what we also need is for valid scientific information to spread peer-to-peer. Why are we keeping it out of their hands?
How could we fix it? Is it Congress? Like, you've been behind the curtain of government. Like, what has to happen? Is it the head of NIH? Can they decree it in a executive action, or do you think it requires a law?
I think there's a lot of ways to go about it. I have worked in government. I'm not a policy maven, so I hesitate to actually give a policy prescription for this. But what I could promise to do is do a little research, and you could put it in the show notes about where the policy stands now. And then people can look for themselves about who to write to or what to lobby for.
Yeah, I love it. Well, let's jump back into your book. And I love it because it's very concise. You can get through it in probably an afternoon. In this book, I honestly loved it as a physician, but I'm also going to send it to my family members. And that's what I think is probably the most powerful thing that comes out of your book for me, is that it really can be this vessel for creating relationships.
Thank you. I wrote Rebel Health to help people step into their power. And that means to step into their power, whether they are patients or caregivers or clinicians, policymakers, or healthcare executives. I wrote it because I realized that I've had the privilege to spend time with patients on the front lines of healthcare. And I had been able to take notes and document how they react when they get a diagnosis or have a healthcare setback. And as my career progressed, I realized that I was working with a lot of people in the C-suite of healthcare who have not had the privilege that I've had, who have not had that time. And so I wrote this book to introduce these two groups to each other. What I lovingly call the rebels of healthcare, and that is the innovators who live at the front lines. They're patients, survivors, caregivers. I did try to open each chapter with a story that would hopefully make you gasp in surprise or have tears come to your eyes. And then I really wanted people to see themselves in these stories and say, I haven't had this kind of experience, but when I do, I now know that I can either become or recruit these kinds of problem solvers to my team, whether I'm a patient or whether I'm a healthcare executive or clinician who's trying to solve a specific problem. You can look at this book and say, okay, now I understand. I need to get the networkers on my side, or I got to attract some solvers to this.
So the framework is that there are seekers, so people that need information. So let's use an example, which you have so many wonderful examples in your book. And I'm going to show my own ignorance here. And I actually say this to patients in the emergency department that come in with a rare diagnosis. I will say, I don't know what that is, or I don't even know how to pronounce it. And I will tell them very, plainly, please educate me. Of course, I'm going to do my best to help you, and I will call whatever consultant, but you tell me. So I'm going to do that with one of the cases in your book. There's a rare condition of facial paralysis.
Mobius syndrome. Mm-hmm.
Yes. So walk us through one of the examples of the families with.
Yeah. So the four archetypes are seeker, networker, solver, and champion. Seekers are people who are not getting the information that they need. They're asking questions and not getting answers, or they don't understand the information. And so they go out online to hunt for more and better information. And a rare diagnosis is a classic example of, or actually a rare set of symptoms that doesn't yet have a diagnosis is a classic seeker challenge. They will go out and try to find other people like them. Mobius syndrome it's about 1 in a million diagnosis by some accounts, and it presents with full facial paralysis. It's the 6th and 7th cranial nerve that's affected. And immediately, that means that a baby cannot latch on to a nipple in order to be fed. And so people are immediately left with this challenge of how to feed a baby. And these days, you can quickly Google that and find out. And there's alignment between the Mobius syndrome community, for example, and the cleft palate community. They also have an immediate challenge of how to feed a baby who's not able to latch on. And when people can now go online and not only get information, but find community, find other people who either live with Mobius syndrome or have babies with Mobius syndrome, that's the magic. That's the magic when all of the other issues can go from, as you put it, I love the distinction, it go from a dilemma to a problem, and they can solve those problems together.
Yeah, it's really, really, really beautiful how you describe that in the book. And it's this beautiful melding of people want to solve problems and exercise their agency. And so they do that. And they also need community. And so I think these peer-to-peer groups provide both of that. And for any doctor that's like, gosh, there's so much misinformation, you actually talk about that in your book and say that there's studies that show that it's actually much lower than you would think. And when people post, and oftentimes I'm sure it's out of not any malice behind them. Sometimes there is. People in the group essentially police it and essentially say, actually, that's not correct, or they post another reference, or depending on the rules, they might pull it down. So I think we've kind of, shocking, House of Medicine has some patriarchal tendencies that the patients actually they're smart, they can figure this out, and literally their lives are on the line. So they're highly motivated to do that.
In expert patient communities, people do swarm misinformation like it's a virus, and the antibodies are strong if it's a healthy online community. Now, the anti-vaccine voices are very loud on social media, and we are living through a time when that is the issue that is gripping society, about whether people are accepting, by the way, not only the COVID vaccine, but as we see also the measles vaccine.
Yes.
Or we could go to the HPV vaccine. These are life-saving vaccines that, because of misinformation and disinformation, people don't fully understand the implications of refusing the vaccine. And that is definitely one section of the internet that is very scary. But the rest of peer-to-peer healthcare is focused on problem solving that has little or nothing to do with vaccine. It's more about, how do I'm living with arthritis. How do I manage my low dexterity? Or I've got a treatment that requires injection and I hate it. How am I going to do this? And with a peer-to-peer group, there are studies that show that medication adherence goes up if people are able to connect with each other and help each other figure out, for example, talk to your doctor, but if you have to do an injection, here's how I do it. And you might get 1 or 2 trainings in the office about how to handle that. But in the middle of the night, or, when the doctor's office is closed, it's going to be a peer-to-peer community that helps you with that.
Yeah, that's really beautiful. The thing I've noticed that's frustrating, and with some of my friends who aren't scientists, let's just use COVID as an example. They said, well, the doctors got it wrong. I love Bill Maher. I watch Bill Maher, and he loves to go on. The doctors don't know what they're doing. They got it wrong. We get it wrong all the time. And what's very frustrating to me is, whether we're talking about healthcare, we're talking about something else on social media, it's a lack of nuance, like critical thinking, that this is the best answer we have right now. Yes, it may change. It's actually a marker of intelligence, not something to be embarrassed or ashamed about. So how do we inject nuance into the internet? Just a really simple question for you, Susannah.
Well, I think that's just the point of our earlier conversation too, which is that science is always changing. And the idea that you can pin it down and say, that's the answer, well, then that person hasn't studied the history of science. And the history of science has changed. And that's uncomfortable. There are people who really wish that we did have all the answers. And there is some settled science, germ theory. Nobody's coming for germ theory right now. But we need to educate people that when scientists are working on discovery, they're going to make mistakes. There's going to be setbacks. And, that is seen, for example, in, we're living through an era where there's more and more incredible work being done in cancer treatment. But there are also setbacks. There are also times when it doesn't work for everyone. And unfortunately, we have to live with that. And how do we educate people to live with nuance? I think we just continue to communicate as best we can.
Mm-hmm. Yeah, for sure. There was an interesting thing that I noticed during the pandemic. I'm wondering if there's any evidence behind it of what you've found. I found that when I would try to have conversations with patients in the emergency department about vaccines or masking or, whatever recommendation I had, they often did not go well. But then when I would do telemedicine and the people were in their own house, the conversations went way better. And my take on it is that there was actual comfort of being in their own space and the safety that, they could, I guess, turn me off if they didn't want to continue the conversation. I think my nervous system was much more regulated. And when I was communicating with people, because frankly, I wasn't worried that they were coughing or making me sick. What do you think about that as a method, or are you seeing any trends that telemedicine can be a place where we could have more of these conversations, in some situations better, perhaps?
It makes sense to me that people would not be as comfortable and receptive in a high stress environment like the ER. And I don't have data about telehealth, but what I can say is that people are ready to receive information in different contexts, and we need to be respectful of that. We need to make sure that there are options for all kinds of people. For example, sometimes if someone has a question, they might feel comfortable talking about it in their neighborhood. They might be comfortable talking about it in their faith community. They might be comfortable posting about it on Facebook, because on Facebook, it's your real name. There are other situations that you are going to want anonymity. And there should also be spaces where you can go and ask a question and be sure that no one's going to judge you. No one's going to know who you are, but you're going to be able to get that information. And I think that contextual understanding of learning, and whether it's information retrieval or getting a question answered, I think that we all need to better understand that and be respectful of people's different learning styles and comfort levels.
Yeah, absolutely. If you had a magic wand, what is one thing you wish doctors did to partner better with their patients?
How many wishes do I get?
Oh, let's go for a little bit.
So, number one, I would love doctors to acknowledge that patients are going to go online and to help them with that and to use it as a signal and as a starting point to say, if you have further questions about this, here are some websites that I've looked at, or here are some online patient communities that I've heard are good. Another wish that I have, especially if this is a doctor's office that treats a specialized type of patient, what if there was a way to connect your expert patient with someone who's newly diagnosed? For example, in the field of food allergy, I happen to have a child with food allergy, and I was able to connect with more experienced parents who taught me things that a clinician who doesn't live with food allergy would not have known how to teach me. Mm-hmm. And I would love for doctors to acknowledge that there are areas of expertise that are outside their own training, and that lived experience can be as important as the evidence base.
Yeah, I am working on my master's in health professions education right now, and part of the classes was qualitative research. And it was the first time that I had been exposed to qualitative research. And it turns out I really like it. Honestly, it's kind of like podcasting. It's a lot of talking and listening. And I think now, if somebody sound bites this right now, they're going to make me look silly, but the whole context of what I'm saying is evidence-based medicine is wonderful. It is very important. It is advanced medical care. There are some things, some issues, some problems that are very hard to address through the current understanding of evidence-based medicine, and especially with quantitative analysis. When I went through medical school, the only things that were ever put in front of me were quantitative studies. I literally had to it was like learning to see a new color once I started to understand qualitative analysis more. So I would just really encourage some more flexibility in the way that you think questions can be answered. And just like you said, we don't have enough time to spend with patients. We 100% don't. And we need to work on those issues. But in the meantime, perhaps volunteer panels at hospitals could include people that are volunteering to be peer-to-peer navigators. Perhaps they want to come and be a standardized participant in the simulation lab. There's just all sorts of ways. I think and again, I'm kind of ranting on the House of Medicine right now. I think we infantilize our patients. And again, if we could use more curiosity and more like asking what they want, what they need, a lot of times they may be able to, like you said, seek, network, solve. I was blown away by the example in your book and I totally had empathy for this person that had diabetes and she's a really heavy sleeper. I've slept through my house alarm and the police coming to my house. That's how hard I sleep after a night shift. And I never thought oh my God, if I had something connected to my body trying to tell me that I was hypoglycemic, and then how they were able to engineer the device themselves. Just another example for the listeners. As you can tell, I just find your book such a needed voice, and I'm really thankful that you wrote it.
Thank you so much. And this was a great segue to diabetes is an area, as is, by the way, substance use disorder recovery and eating disorder recovery. Those are areas where this is really settled science, that peer navigators are used as a matter of course in those areas. And what I would argue is that all disciplines, all areas of healthcare can look to peer-to-peer healthcare as a way to leverage this untapped reservoir of energy of not only peer support, this idea of, the cool cloth on a forehead of finding someone else who's going through the same thing that you're going through, as well as real world problem solving. You're describing the conundrum that Dana Lewis was facing when she couldn't get the manufacturer of her continuous glucose monitor to acknowledge that the alarm was not loud enough. They missed an opportunity to learn from a customer. And what happened is that patients and caregivers themselves were able to essentially hack into the continuous glucose monitor, send the data to an Apple Watch. Dana was basically handy enough to be able to then rig up an external alarm that was loud enough to wake her up. The Diabetes Rebel Alliance represents the full stack of the patient-led revolution: seekers who go out on the hunt for something better, networkers who then disseminate what they find and gather in community, solvers who attack problems, who can't wait to take something apart and put it back together again better, whether it's a medical device, an assistive device, or a system. And then the fourth group are champions. Champions are people who have access to mainstream resources that they then direct or share with a patient-led team. And in this case, the champions were people, for example, at the FDA, who looked at what the patients were doing and said, as long as you don't sell it, it's not illegal. And they helped to advocate for the medical device manufacturers to start giving people access to the data that's generated by their own bodies.
Wow. Well, this has been an amazing treat to have you on the podcast. I am so thankful for your leadership, your innovation, and I'm actually going to a shift. I'm in my scrubs. I am going to have to raise my game today on my shift and think a bit differently, which is awesome. How can our listeners get a copy of your book?
It's available wherever books are sold. And my website is susannahfox.com, SUSANNAHFOX.
Wonderful. And you are on social media. What are your preferred platforms right now? What's the best way to reach you?
Oh, goodness. LinkedIn is probably where I'm spending the most time. Twitter was my first love, but I'm going to go down with the ship. But you can still find me on Twitter. On Threads, I'm Susannah R. Fox. My middle initial is R, as well as on Instagram. Same handle.
Okay, awesome. Yes, I guess was on X today, and I was on Threads and tagged you in the conversation. I would highly encourage our listeners, buy this book for yourself and buy it for your family. I would suggest for our listeners, if you found this episode interesting, go back to the one with Gina Siddiqui. Gina Siddiqui has CART clinics in which she essentially provides physician support. It's not a doctor-patient relationship. It's like an expert support. And I'm really interested if maybe there's some synergy with your work in Gina's. But I would encourage people to buy this book for their family members, because circling back to Gina, her company started because people come to us all the time. Like, I've got this diagnosis, or this is what's going on. What do I do? But I love this idea. And somebody recently shared it with my family of like, hey, have you thought about trying to link your mom up with a caregiver support group? And this is still like very counterculture in medicine. And I think we're making our jobs harder, which isn't a surprise given the psychology of physicians. But I'd really invite people, like, start talking to your social workers and case managers. I'm actually going to ask, this is my personal call to action today. I'm going to ask my case managers and social workers, can you just give me your binder? Can you just give me your little magic binder that has all the people and all the contacts? Can I just have a copy? Because they're not always present. But if I have the binder, I can at least flip through it. Maybe we can start to make some QR codes. And that's what I'm going to do differently today, Susannah.
I love that. I think healthcare is currently leaving half the team on the bench. We are not leveraging the patients, survivors, and caregivers who could help us heal healthcare.
There's no better way to end the episode with that, is we are leaving half of the participants on the bench. So thank you.
My pleasure.
Thanks for listening to Heartline, conversations with healthcare changemakers following their heartlines. I'd so appreciate it if you could take a quick moment and hit the like button and also the subscribe button that you'll find within your podcast app or platform that you're listening on. It also really helps if you can leave a review. I would certainly appreciate a 5-star review and a few comments about what you liked about this podcast. Don't forget, you can also forward this to people in your network. People love getting new podcasts and changing up what they're listening to. So sending a podcast to a friend or colleague, or even to start a conversation about a change that needs to happen in your organization, is a great way to be a change maker. This podcast represents the views of the host and guests. It does not represent the views of any entity we work for or with. It is also for informational use only and does not replace any professional advice, including medical or psychological. If you are interested in unlocking your true potential, reach out to me. If you're an organization interested in supporting the well-being of your people, I'd love to connect on innovative solutions. Schedule a strategy session at AndreaAustinMD.com. Sound editing services are provided by Better Podcasting Services, and you can find their website at betterpodcastingservices.com. And I'd also like to thank our future Dr. Caitlin Din, who is the production assistant for this podcast.